AETCM, the emergency medicine channel. Shall I start, sir? Present in the case of a 56-year-old male, known case of decompensated CLD with portal hypertension. He came to ER with complaints of diffuse abdominal pain and abdominal distension following an ascitic tapping procedure done in outside hospital about 2 hours back, in which the fluid came out to be a blood tinged ascitic fluid.
Okay.
So on an initial 10-second assessment, the patient was conscious oriented. He was talking in full complete sentences. The air was patent. There was no presence of any pooling of secretions or gurgling sounds or stridor. Breathing wise, the respiratory rate was 20 per minute, and air entry was bilaterally equal with no added sounds. And the saturation was 98% in room air. And the circulation wise, the BP was 120/70 millimeters of mercury with a pulse rate of 98 per minute and a capillary refill time of less than 2 seconds.
Okay.
And disability wise, the GCS was E4, V5, M6, and pupils were equal and reactive to light of 2 mm. And the exposure wise, there was no presence of any external rashes. The temperature was 98.2 degree Fahrenheit and GRBS was 78. Okay. And we have also assessed the pain score of this patient. The pain score was 7 out of 10.
Okay.
So for this patient, we had initially given an opioid, so an injection tramadol, 50 mg in 100 ml NS with the MSA injection metoclopramide. MSA was given, 4 mg IV stat was given for this patient on dancer.
Okay.
And after that, we had attached 2 large bore IV cannulas for this patient because this patient we came to a diagnosis that this patient has had a traumatic ascitic tap.
Okay.
So which is a hemorrhagic ascitic tap is what we came to the primary conclusion. And as a part of initial volume resuscitation circulatory to prevent the circulatory compromise, we had attached 2 large IV bore cannulas and have arranged for blood products. So initially itself we had arranged for 2 units PRVC and 4 bag FFP, and we are given for 8 unit RDP also. And we had done the point of care, CBC CRP was done. For this patient, the patient had total counts of 5,000 with a HB of 10.6. The previous HB 1 week back was 11.
Okay.
And a platelet count of 76,000 and CRP of 1.2. And this patient was also taken a venous blood gas showing an HB of 10.4 with a lactate of 3, creatinine of 1.2. There was no presence of any acidosis or alkalosis in this patient and bicarb of 18. And so then we had asked the sample history. The patient was a 56-year-old male. He was a known case of decompensated CLD with portal hypertension, and he had massive ascites and was to undergo ascitic tapping in outside hospital, where after they attempted the tapping, initially there was a clear fluid, then it became blood tinged. So following which then the patient developed increased abdominal pain. So this was the symptoms which he had we developed there 2 hours back.
Did they specify the quantity, how much they had drained?
As soon as the blood had come from the drain, they had stopped the tapping. They had just drained about 10 to 20 ml.
That's it.
Yeah, that's it. Following that, the tapping was then traumatic. So there's no history of any vomiting, or there's no history of any associated constipation or associated fever associated with it. And there's no history of any bleeding from other lower GI bleed. There's no presence of any melena
or facial bleeding.
Facial bleeding was not present. And there's no.
Sorry, Dr. Amal. This patient, just immediate after the hemorrhagic tap, he's presented here.
Yes.
Or is it after a day? No. As soon as the hemorrhagic tap was there, they stopped the tapping and they shifted the patient.
They shifted the patient to here for further evaluation and treatment.
Okay, carry on.
Yeah, so this patient has now had a recent trauma to the abdomen. There is no history of any previous trauma to the abdomen. So I just asked for a previous history of any trauma to the abdomen. And there is no history of any associated the abdominal pain. There was no history of any radiation to the back, or there was no history of any radiation to the groin region.
Okay.
We also continue to ask the further history of the allergic history. The allergic history, the patient did not have any allergic history. The medication wise, he was using Udiliv and Lasix tablet. So then we had moved on to the labs. We had also sent the samples to the labs. The INR of this patient had come to be 1.37.
Okay.
And the pH was the platelet was 76,000.
76,000.
Yeah. So and we had done a USG, the local site, look for the what was the presence of echoes, presence of clots were present or not. And in the USG, we were able to find multiple clots present inside the ascitic fluid area. So then we came to a conclusion that the tap was a traumatic tap, lead to a hemorrhage.
Okay.
So that's following which we did a Doppler study, following which there was found to have an extravasation from the inferior epigastric artery, USG Doppler. And so following which we had given an IR consultation.
Oh.
So from the IR side, they had initially did a after admission they had did a radioembolization.
Okay.
So this was the later did it, but initially itself this patient had following this blood loss, the patient had developed a minor episode of hypotension during the course of the year. So then we had to we again checked the blood counts. So the HB had dropped to 9.6.
Okay.
So there was a drop of 1 unit and a hypotension associated. So we had to transfuse 1 unit PRBC.
Okay.
And then the patient was then sent for surgery and was stabilized.
Yes. Okay. It's actually a wonderful case for discussion because abdominal paracentesis is one very common procedure that we do it in the ER and many other hospitals as well. So because it's very commonly done, these are some very rare complications that happen. And most of the time when such complications happen, we do panic because we don't exactly know where is this originating from and what are we supposed to do. So good that you brought up this topic for discussion. So let's, because we are having the topic of ascites as the discussion here, let's get into the basics of, how does ascites happen. Could you just dwell into the pathophysiology of ascites?
So according to the various pathophysiology includes there could be a presence of increased hydrostatic pressure. So
when it comes to cirrhosis being the cause,
yes.
Then because of the back pressure, there is increase in hydrostatic pressure, and also because the production of albumin is also decreased. Then there will be decrease in plasma oncotic pressure, which eventually leads to epithelial leakage. Right.
And another thing is the splanchnic vessel vasodilatation. So that's one of the reasons. So due to this back pressure, there will be this splanchnic vasodilatation leading to increased flow. That is the fluid. Right. So that's from the ascitic fluid. Another theory is the lymphatic drainage. So that the increased lymphatic drainage is blocked due to the change in the ecotexture of the liver. So that's in case of a liver cirrhosis.
So adequate clearance is not happening, and there's blockage which leads to back pressure again. So again, there will be more ascites. Right. Now, whatever you talked about is mostly in case of transudative effusion. Yes. So what all transudative effusions? What all can it be? Ascites, sorry.
Yeah, transudative ascites most probably could be due to an underlying liver pathology like liver cirrhosis, or could be a renal pathology like nephrotic syndrome.
Yes.
Another could be in case of congestive cardiac failure.
Congestive cardiac failure.
So that's also
right. So exudative effusion.
Exudative usually due to an
infective or any inflammatory status, malignancy. Can be peritoneal metastasis. Yes, it can be TB. Right. Yes. Right. How do you differentiate between these two? What is the most sensitive test?
We check the serum albumin and the ascitic albumin gradient. So the SAG is what we usually check.
Yes.
In patients with transudative effusion, like transudative ascites, they will be having a low SAG.
It will be more than or equal
more than 1.1. So they will high SAG.
Yeah, high SAG.
Yeah,
high SAG.
And in exudative, they will be having a low SAG.
Low SAG.
Yeah, because there will be increased albumin leakage.
Right. So yes. Now when we talk about the complications in when we do ascites, before we go into that, what would the precautions be, or what all would you be ready for before you do an abdominal paracentesis? What all are you going to do?
Yes, the first initial thing is we should know whether he is a candidate, is an ideal candidate to do a paracentesis. We should initially know about, we should earlier itself do an USG to look about the amount of fluid. Free fluid is present or not. That's the initial thing. And the second thing is we need to get a consent.
Very important.
So consent is
pure consent, explaining the relatives and the patient regarding the adverse effects that can happen, and what are the benefits and the risks that the patient is undertaking before doing the procedure. Right, and you get all the equipments in place, you get your nursing staff to assist you, you have your ultrasound in place and everything. Yes. Right, that's what you do before this. So let me some of the studies that recently have published amongst the journals of gastroenterology is that they did a systematic review of literature regarding ascitic tap and found out that the actual complications associated with ascitic tap is actually very, very low compared to the number of procedures that we do. Very few, around 61 patients actually had complications, out of which the most common complication was hemorrhagic tap, like the case that we saw. Out of 61 patients so far they had some around 46% of patients who had hemorrhagic tap, and the most common causes for tap would be
so there are actually three causes. So initially the first one could be due to an abdominal hematoma due to the traumatic. So that is the most common cause.
Yes.
So the second one could
abdominal
be
wall hematomas.
The next one could be a presence of an pseudo aneurysm of the inferior epigastric artery. So that's already found like it was not found earlier, and that could have been lead to a delayed rupture. So that can also lead to this presence of bleeding.
Yes.
So that's initially that will be clear. It will be presenting as a later complication.
Right.
And the next one is a hemoperitoneum, which is usually due to injury to the mesenteric varices. So mesenteric varices bleed. So that's also another possibility.
Most common thing.
Yes.
The other complications would include bowel perforation, infection, and all that. Right. Okay. So if you're going to tap this patient, is there any particular patients whom you should be, having a very low threshold, knowing that, okay, these patients might end up having more adverse effect than compared to, or complication rate compared to the other subset of people?
Yes, especially in patients with decompensated CLD, as in patients of child C. So
child pug C or more.
And so that's with a high MELD score. So such individuals are always prone for increasing, they have a chance of increased INR. So like coagulopathy, increased coagulopathy or
low platelet
count. And also patients with an underlying renal dysfunction. So if patient is having an underlying hepatorenal syndrome, the morphology of the platelet will change and there will be reduced platelet vessel wall adhesion. So that can also lead to increased chances of bleeding, even on a trivial trauma. Yeah, so that can be, they are high risk for increased propensity to bleed even in a minor trauma.
Right. So these patients you should have, you should be on that lower threshold, get everything arranged before you proceed with it.
Yes.
Right. And actually the data says that if at all the patient bleeds, then the around 40% of the patients who eventually bleed might require an intervention.
Yes.
So most commonly, what we rightly did here, it is IR intervention that is mostly required, and a few subset of patients might require explorative laparotomy also to find out this thing, but that doesn't end well according to the data. So why I'm saying this is because if at all we have a TAP, start your conservative management immediately, but immediately involve the other departments as well. They can help you if things go wrong. It'll be good for the patient as well. Right.
And we can also try a local site injection of thrombin.
Okay.
So thrombin injection can also be given as part to reduce the bleeding into that vessel.
All right.
So that can also be done through the intervention radiology. Okay. They usually do that.
Do that as well. All right. Oh, okay. Great. So if at all the bleeding happens, like you did ultrasound and you got the pocket and everything, and you did this thing, but unfortunately the bleeding started. what all precautions would you take immediately?
Yeah, so initially itself, the first thing is the local application of local pressure.
Yes.
So that is the initial thing. If it's like a superficial bleeding or hematoma, what we get in the beginning, the first thing what we do is the local pressure dressing and ice packs. So that we initially do it and observe. That is the initial thing what we can do. But if the patient is still ongoing, then we can do an ultrasound. So look for the presence of any clots is present. If there is presence of increased active clots, there can be the presence of an ongoing bleed. So active clots means an ongoing bleed. So in such situations, we should do the volume resuscitation and correction of the coagulopathy. So there is a correction of coagulopathy is usually done by if patients having a platelet count of less than 50,000. In our individual, the patient had a platelet count of 76,000. So if it is less than 50,000 and active bleed, we must transfuse platelets. So that is the first thing. Then second is to look for the IFFP or prothrombin complex, which we usually give if the patient is having an INR more than 1.8 with active bleed. So in our patient, the patient had an INR 1.34. So the patient was not a candidate to receive an FFP at that moment.
Okay. But before you get the blood products, what else will you have to do? You give pressure.
Yeah.
What else will you do? The immediate thing that will be available next to you would be, if at all the BP drops, would be fluid resuscitation. Keep the patient in supine position. So follow all that.
Yes.
Just seeing. Then you get the blood products arranged, get the consults, the relevant consults required.
Yes. Tranexa also has a role. Injection tranexamic acid has a role in reducing the amount of bleed.
Okay.
According to recent studies.
All right.
And then the next is cryoprecipitate. If we should check the fibrinogen levels. Fibrinogen levels is less than 100. Then we should supplement with fibrinogen also.
Okay. If at all you don't have an ultrasound machine and you don't have Doppler to confirm the vessels and everything, which site would you recommend for a blind procedure?
It's usually a site of 2 to 3 centimeters medial from the anterosuprailiac spine. So we prefer the left more than the right.
All right. Any particular reason why you would prefer the left over right?
Usually in the right side there will be presence of cecum. So the cecum can lie more anteriorly. So there can be increased chance of bowel involvement.
Very good. Whenever ascites is there, cecum dilatation will happen, and as you rightly said, an anterior movement will be there, which will be more risky because when you do a blind procedure, you might end up giving a bowel perforation. So it's better to choose the left side, as you rightly said. Good. And if at all you're doing a large volume paracentesis, can you talk about the plasma volume expansion that you should be doing associated with this?
So in case of massive, we are doing a massive therapeutic tapping. So in such individuals, it will be like if the patient is, we are tapping more than 5 liters. In such individuals, we should give a plasma volume expander. That's example is an albumin. So human albumin is one of the examples. In human albumin, it's usually at a dose which is between 6 to 8 grams per liter. So that is the per liter of fluid rate. So the 100% human albumin, what we give is
20%, 100 ml. So you give around 2 bottles.
Yeah. So we have to give 2 bottles.
Yes. Why do we give that?
So that this albumin has a role in the reduction of the oncotic pressure. So the oncotic
increases the plasma oncotic pressure.
Yeah. So that increases the oncotic pressure. That's another factor. And
when we do abdominal paracentesis, a large volume, more than 5 liters or something, if you're tapping, the abdominal pressure is actually very high in a tense ascites, right? So this is actually compressing the splanchnic vessels. So when you remove so much, what happens is sudden decompression. There is associated splanchnic vasodilatation, which leads to effective arterial volume suddenly decreases. This would decrease the renal perfusion, and also the RAS gets stimulated, renin-angiotensin-aldosterone system, which leads to sodium water retention. So effectively, the blood volume or the effective arterial volume decreases, which will lead to the patient going into hypotension, renal dysfunction, and also because of sodium water retention, there might be sudden rebound ascites as well, which will again decrease the effective plasma volume. So this will lead to hypotension. So that is one of the reasons why, along with large volume paracentesis, we give albumin. All right. Anything else that we have to discuss?
Yeah. So these are some precautions just to avoid traumatic tapping. The first thing is always, if you have a USG guidance, always use USG, guidance and look for a good pocket. So that's also always important.
Doppler to confirm the vessels.
And also we should do a Doppler to confirm
the vessels in vicinity.
Yes.
Preferably guided tap should be done.
Yes.
We discussed about what should be done to manage the sudden hemorrhagic tap.
And also look for the INR levels.
INR levels, if at all it's possible. And then
platelet count also.
Platelet count.
And fibrinogen levels.
Discussed about the anatomy, what all can cause the bleeding. Discussed on what all should be done immediately. Blood products, super specialties to be involved. That's pretty much it. Thank you.